Hi everybody, let's discuss the basics of restless leg syndrome. You're going to see restless leg syndrome more in females than males. And also this is a disease that progresses over time. Now what do I mean by that? No, I'm not saying it's going to get worse day to day. What I'm saying is months or years down the road, if you have symptoms of restless leg syndrome now that are untreated, years down the road, those symptoms will be worse. And I haven't really discussed what they are yet, but we will discuss that later. There is also an association between periodic limb movement disorder and restless leg syndrome, PLMD, periodic limb movement disorder. Up to 85% of people with restless leg syndrome also have this disorder, which is defined as involuntary forceful dorsiflexion, which means kind of the toes coming towards the head, of the foot that occurs every 20 to 40 seconds during sleep. Usually it's noticed by a partner, a sleeping partner, if the patient who has PLMD is kicking their leg every minute or so, sometimes more often, they may also have another disorder going on. Restless leg syndrome is going to more occur going to sleep, while periodic limb movement disorder may be associated with an involuntary leg movement during sleep. If you have both of these diseases together, typically you're just lumped into the category of restless leg syndrome and not diagnosed with both at the same time. You're just diagnosed with restless leg syndrome. Kind of like the trump card. Let's just explore a little bit about the pathophysiology behind restless leg syndrome. I'm not going to get into it completely because even some of the research that's going to be out there is a little above my head. However, there is going to be a strong genetic component. So if you ask a patient if they have restless leg syndrome, or if their parents had restless leg syndrome, they'll be like, oh yeah, they were diagnosed with restless leg syndrome, or oh, I had an aunt or I had an uncle who had this disease as well. What it is it's thought to be impaired iron regulation or homeostasis within the body. So iron stores are just not working correctly, or the iron's not being utilized correctly. Also, there's a thought that there's impaired dopamine pathways, so they're subcortical, meaning they're deeper within the brain. Dopamine is just a neurotransmitter. It's a substance created by the brain. The brain creates tons of different substances, and dopamine is one of them. And then the thought is that there's an impaired pathway somewhere in there, deep within the brain. Then also, restless leg syndrome can also be secondary to, this is kind of my shorthand, secondary to a folate or a magnesium deficiency, could be secondary to a disease like diabetes, amyloidosis, Lyme disease, or even pregnancy. So pregnant women can develop restless leg syndrome. This is going to be more of a primary or an idiopathic reason why you develop restless leg syndrome, while this usually as the pregnancy resolves, the restless leg syndrome will resolve as well. So usually it's secondary to another disease. Once that disease is well controlled or managed, then restless leg syndrome may lessen. Let's move on to the diagnosis. That's my shorthand for diagnosis. There's going to be multiple components to restless leg syndrome. The first is going to be you have an urge to move the legs. That usually is followed by a discomfort if you do not move the legs. So let me say that again. You have an urge to move the legs. If you do not move your legs, you'll experience an increasing discomfort. Usually this discomfort is going to be worse with inactivity and at nighttime. And then also, if you do move the legs, that discomfort decreases. So the discomfort created by that urge is going to be decreased with movement. So kicking your leg or repositioning, for example. Also, it has to be not due to another disease like intoxication or a medication side effect, for example. These are some of the Dsm-5 criteria. However, for diagnosis, really it's going to be a patient-reported disease. There's no magic blood level that we can determine for restless leg disease. We can draw for iron levels. However, this is really a patient-reported disease. The Dsm-5 criteria is going to be a psychiatry group criteria, meaning this is going to be the most up-to-date psychiatry recommendations. Now, I know when I say psychiatry, usually there's bad connotation. Oh, it's either all in my head or it means I'm crazy. No, neither of those. What it is it means that usually there's some psychological component to this disease. So it kind of ventures into the realm of psychiatry here. It is going to be patient reported to diagnosis. So some of the problems that you'll see are going to be sleep problems, difficulty initiating sleep because of that discomfort in the legs. Also, you may see daytime fatigue because if you're not able to sleep okay, then you may have fatigue. So then we kind of move into the treatment of restless leg syndrome. Some of the non-drug or the non-pharmacologic treatments that we have are going to be exercise. Remember I said that restless leg syndrome is the symptoms are going to be worse at night. And they're also going to be worse with inactivity. So if you're active, it's thought that that may help decrease the discomfort, therefore helping the restless leg syndrome. Also, some antidepressants such as SSRIs should be discontinued. It's just thought that one of their side effects may build up into restless leg syndrome. Also, you should avoid substances like caffeine, alcohol, and nicotine to help with the treatment. Also, you have some drugs in your toolbox. If you're studying for the USMLE or the COMLEX or PA test, whatever you're taking, the kind of number one agent that you'll see in study material is going to be ropinirole. Ropinirole is going to be a dopamine drug. It's going to be a dopamine agonist, where you may also see pramipexole. Pramipexole is also going to be kind of in the same category as ropinirole, and also bromocriptine. So your dopamine drugs. Remember, thinking back, let me go back a few slides. I said that an impaired dopamine pathway somewhere in the subcortical region of the brain is going to be thought to contribute to the restless leg syndrome. So if you give some dopamine drugs, that may alleviate some of the symptoms. Also, benzodiazepines such as clonazepam. You have your opioid drugs like codeine, for example. You have your anticonvulsants, which can be tried, like gabapentin. Your alpha-2 adrenergic agonists, which is clonidine, is the number one example there. However, so I left this one blank on purpose. I want you to think, what is the number one drug that we should always start for restless leg syndrome? No, it's not going to be ropinirole always. The number one drug, and I say that because it's going to be safest. In most cases, it's going to be the safest drug to start. And that's going to be iron. So iron. Now I'm just going to write iron again up here where I have a little more room. Iron, I say it's the number one treatment because the impaired body's homeostasis of iron is thought to be contributing towards restless leg syndrome. Let me go back in case. Impaired iron in the body. So somewhere in the body's pathway of iron usage, there's going to be a problem. So the number one easiest way to treat restless leg syndrome is to draw up a ferritin level. Ferritin is just going to be a reflection of the iron in the body. Or if you don't want to use a ferritin level, you can do an iron panel. That iron panel is going to consist of an iron level, a ferritin level, a TIBC, and a transferrin saturation. So, if they're borderline on the iron or if they're low on iron, the easiest way to treat pharmacologically restless leg syndrome is going to be replacing iron with iron supplements. If they're high on iron, you probably want to hold off. You don't want to give them more iron if their iron levels in the body are high. So iron, usually it takes about 3 months to kind of build up and create an effect. Also, to absorb iron, you need vitamin C. So make sure you're taking either a vitamin C supplement or drinking orange juice or taking foods high in vitamin C. So iron is going to be a good treatment. Some of the side effects you may see is going to be constipation. That's really the number one thing that you need to be warned or worried about is going to be constipation with iron supplementation. So otherwise, if their levels are high, or if you've tried iron supplementation, then you can go on to your dopamine drugs like ropinirole. That's going to be kind of the next best agent. Or if that doesn't work, you can try really any of these. Like I said, there's some psychological component. No, it's not that you're crazy. You're not making up that your legs hurt. It really, honestly, is discomforting to the patient. However, any of these drugs may help as well. So let me see here. Here's the source that I use. Also, I learned other information on my clinical rotation. Hope you found this video useful, and if you have any questions, make sure to ask. Thanks.